all questions are welcome, but also please do be respectful with your comments and your interactions. Third, if you haven't already, don't forget to sign up for the TB-Mac newsletter, join the TB-Mac workspace on Slack, and follow at TB_Mac on X, formerly known as Twitter. I think Ben is going to put links for each of those in the chat now. And finally, if you would be interested in presenting your work at an upcoming seminar, please do reach out. I believe you can get in touch with Finn if you are interested. Perfect, I see a thumbs up there. Now on to today's seminar. Today we're going to hear from Mmamapudi Kubjane on her work modeling the South African TB adult epidemic, exploring the effects of HIV, sex differences, and assessing the impact and cost effectiveness of TB program interventions. Mmamapudi is a South African epidemiologist and modeler interested in modeling TB and the population level impacts of interventions. She's particularly interested in interventions to address social determinants of TB, post-TB sequelae, and TB-associated catastrophic cost. She recently completed her PhD at the University of Cape Town, which focused on modeling TB in South Africa and contributed to the development of the Tembisa TB model. She's currently working at the Health Economics and Epidemiology Research Office, supporting the development of the TB investment case. So thanks very much for joining us today, Mmamapudi. Congratulations on the PhD, and I'll turn it over to you now.
Okay, thank you very much for the introduction and for having me. I'm going to try and share my screen. Let's see. Is it clear? Okay.
Perfect.
Cool. Okay. So as mentioned in the introduction, I'm just going to put my video off. So I'll be talking about the work that I've done on modeling TB in South Africa and the impact of interventions, and also the current work that I'm doing at HERO, which is focusing on building up on the TB investment case, but the main analysis is estimating the impact and cost effectiveness of TB program interventions in South Africa. So yeah, I'll go through, give a background and an overview of the methods, which I will be very brief, and then go through the various pieces of analyses that most of them have been published already, but I'll also present some of the ongoing work much later on. Okay, so as we all may know, TB is still highly prevalent in South Africa and a major challenge. But what is also clear is that it's much higher among men compared to females, indicated by the incidence to notification ratios much higher in men. While we know HIV is the strongest risk factor in South Africa, there are other highly prevalent risk factors, including undernutrition, smoking, diabetes, and smoking would contribute to TB in South Africa as well, and these also vary by sex. So some of these risk factors that are highly prevalent among men include smoking, alcohol, and undernutrition, and others include occupational risk factors such as mining, and congregational settings such as being in bars or shebeens, and also exposure to silicosis, which is usually from mining industry, and also in the prisons. And these are well-established TB risk factors that are associated with increased risks of developing TB disease. And while HIV is the strongest risk factor, it's much more prevalent in women in South Africa. So the high rates of TB are not new. They've always been there, at least in South Africa. Shown here is a an analysis that was done in the early 1980s, that the male to female ratio for TB notifications was around 1.6, between 1.6 and 1.8. So despite TB still being high, South Africa has implemented various interventions to control TB, and among these which are established to be in place include DOTS, the rollout of ART, intensified screening activities, and provision of preventative therapy, and the rollout of Xpert to replace the previous diagnostic tools as first line, mainly smear microscopy. And these have contributed to reducing TB in South Africa. But also in 2019, 2020, we experienced the COVID epidemic, which regressed some of the efforts precisely by reducing the rates of TB incidence decline and slightly increasing mortality. And so the prospects of reaching the NTB targets for the nearest coming ones for 2030 still remain uncertain. So yeah, just to give an overview for the analysis that the results of the analysis that I'll be presenting are based on the Tembisa TB model. And I'll just give a brief overview of the methods. If there are any further questions, you can ask me, or I can refer you to the papers which were published. So the Tembisa TB model was an extension of the existing HIV model. It is a compartmental deterministic and is integrated into the known HIV model. It is informed by various South African demographic and epidemiological data and we only include the adult population from 15 years and older. And we also include various literature review parameters. Parameters are informed by literature review, estimates from the literature review. The model includes simplified social mixing patterns informed by community social mixing surveys. And also we do include a diagnostic pathway, simplified. We track patients, TB patients, based on symptoms and smear status from to attending healthcare, getting diagnoses, initiating treatment, and also treatment outcomes. The model was calibrated to various South African data, including treatment initiations, deaths from the vital register, and microbiological tests from our National Health Laboratory Services. And we also used the TB prevalence survey from for the estimates for 2018. Yes, so we used a Bayesian calibration approach to ensure that our model estimates are consistent with the data that we provided or we find from various reports, and to also estimate parameters that are unknown or have uncertainty, and posterior distributions for these various factors are simulated numerically using the incremental mixture importance sampling. Okay, so these figures show the model calibration to the two calibration targets for TB prevalence and for TB mortality. And the blue is for males and red for females. And as we could see, the model did fairly well in capturing the trends and also showing a much higher prevalence and mortality in men compared to females. Similarly, for treatment initiations, treatment initiations were higher in men compared to females, but our model did not capture the trends very well. This is possibly due to our model underestimating, particularly for the men, and also slightly overestimating for females in the earlier years. Okay, so in this next set of results, I'll be showing the analyses that focused on the historical impacts of interventions and HIV on TB. So the first will focus on the TB incidence and mortality attributable to HIV, and then look at the percentage reductions in TB incidence and mortality due to the various interventions that we and looked at. So the general approach is we would simulate counterfactual scenario in which we either do not include HIV or the intervention that we are looking at, and then estimate the TB incidence or mortality, then compare that to the baseline scenario where all of these factors are present. So where HIV and the interventions are present, and the difference allows us to, of these estimates under these different scenarios, allows us to estimate the incidence and mortality attributable to HIV, and also the percentage reductions due to the interventions. So this figure shows the HIV trend or the TB trends if there was no HIV in South Africa. It would have lied within the range between 1990 and 2019. It would have been between 100,000 to about 140,000 in absolute numbers. While this is low in terms of South Africa, South Africa would have still been classified a high burden country, so it would have still been high relative to other countries. And this is what we observe with HIV present in the population. Overall, we estimated that about 8.8 million people develop TB, and about 55% of this is due to HIV. For mortality over this period, we estimated that about 2.1 million people died due to TB, and about 69% of this was due to HIV. Okay, in this next set of results, I'll be showing the impact of interventions. Okay, first, we just restricted to 10-year period between 2009 and 2019. We estimated a decline in TB incidence that it was about 30%. And in the presence of all the interventions, about 2.1 million new TB cases were averted. These are cases that would have happened if there were no interventions. And when we looked at the interventions that led to the most impact, so blue is for dots and green representing the intensified screening and ART in red. What is clear is that ART and intensified screening explained majority of the declines throughout the periods from when they were implemented. And the other interventions, IPT, Xpert, and DOTS, led to reductions ranging between 0.2 to about 4% over this period. Okay, so in the next set of results, I'll describe the results we found from the analyses that explored factors that drive sex differences in TB in South Africa. So we also wrote a piece for The Conversation Africa, and surprisingly, it seemed to grab interest from mainstream media. After this, we got some requests to do some mainstream from TV and radio interviews, which was interesting. So the main objectives were to explore the contribution of HIV testing rates and ART uptake, and the specific risk factors that we looked at smoking, alcohol abuse, undernutrition, and diabetes, and also looked at social mixing rates and health-seeking patterns, and also treatment discontinuation. And we estimated the population attributable fractions due to risk factors, and also the effect of these changes in these risk factors on male to female ratios. So the general approach we used was to use estimates, so the relative risk estimates of the TB risk factors obtained from the literature, and also the sex-specific prevalence of these risk factors in South Africa. We used various surveys, and that's also the main reason we went with this risk factors based on the availability of this data. So we assumed a multiplicative effect and applied these risk factors onto the rate of progression to TB disease in the model. And similarly, the approach is we simulated counterfactual scenarios where we simulated where HIV there was no ART, and without the risk factors, and compared this to the scenarios where HIV and ART were present, and also the risk factors are present, and the differences allow us to estimate the attributable fractions, and also the incidence and mortality due to HIV, and reductions due to ART. So these figures show the male to female ratios between 1990 and 2019. What is clear is that they've remained consistently above 1, meaning they've always been higher. TB incidence and mortality has been higher in men than females, but also we see changes in the trajectory, and we hypothesize that this could have been due to the effect of HIV coming up in the early 1990s. So we first simulated a scenario without HIV, that what would have happened to the male to female ratio, and the model suggests the TB rates would have been at least double in men compared to females. And if we said it was due to HIV and ART, so we simulated a scenario without ART in the model to see what would have happened. So in the red line, we can see that from the mid-2000s, the trajectory would have continued to kind of go much lower than picking up. And this is because during the mid-2000s, with the scale-up of ART, because females were more likely to be tested and initiate on ART, they were more likely to benefit from ART, and hence reduced risks of TB due to HIV. Whereas in the early 1990s, because of the rapid growth of HIV, which was much higher in females, the reason why it dropped so rapidly is because females were getting developing TB rapidly due to HIV, but with ART, this got reversed, and that's why we see as in the baseline, it's kind of picking up again. The male to female ratio is rising up again, and the same pattern also follows for mortality. Okay, so we also estimated the male to TB, the attributable fractions for the risk factors. As I just mentioned earlier, that HIV, because HIV is much higher in females, it still contributes more to females getting TB in South Africa. Similarly with diabetes, because they're more prevalent in females. But with the other risk factors, particularly alcohol and smoking, excuse me, and undernutrition, they contribute more to the TB incidence in men compared to females. And lastly, we did this analysis where we looked at the effects of removing these risk factors in the model and how they influence the male to female ratios. As expected from the results that we saw, the HIV and ART led to major changes in the male to female ratio, and also smoking and alcohol explain a majority of the changes or the increase in TB incidence and mortality in men. And the others had slightly lower effects. Okay, so in this next set, we'll be looking at we did a comparison of the model estimates from our model to the IHME, and which is the global burden of disease for TB, and also the WHO based on the 2020 report. And all these estimates are for 2019. So when we did this analysis for overview, what to note is that our model does not include the child TB population. So as expected, our estimates would be lower than the IMHE and the WHO, but for TB incidence, we estimated much lower, even considering that we may have missed the childhood population. Another starking difference was that the IMHE estimated a slightly lower TB incidence in the HIV population, but for our model and the WHO was fairly consistent. And for the comparison of the estimates by sex, our estimates were fairly consistent with WHO, but the IMHE was different, but specifically for the new TB or TB incidence, estimating men to be slightly lower, and this is not what we would have expected. While it wasn't a very systematic analysis to explain why these differences exist, some of the possible explanation could be due to data sources and the modeling approaches. What is coming through from reading the other analyses, so the IMHE relies largely on mortality for estimating TB incidence as well, and also for estimating mortality. For the WHO does use prevalence survey, assuming some disease duration, and we used obviously a transmission model also incorporating effects of HIV and other interventions. So yeah, I think to get more clarity on the drivers of these differences, we would need to conduct more systematic analyses to understand and also explain why these differences exist. Okay, in this last piece of work, I'll be describing the work that I'm currently working on, which is estimating the impact and cost effectiveness of TB program interventions in South Africa. And this is part of the TB investment case for South Africa. And all these results are still preliminary, and I'll really take any feedback for something that's starting to be need revision or any input. So just to mention, the initial part of the model, the Tembisa model, did not specifically include drug-resistant TB. So for the purposes of this work, well, Lee Johnson, he's not attending this talk. He worked on adding additional states for drug-resistant TB. And this is basically adding rifampicin-resistant by smear status and also rifampicin on treatment. And also they calibrated the model to various data sources, including the National Drug Resistance Survey and the number of resistant TB cases in the that are diagnosed from the National Health Laboratory Services databases, and also the treatment initiations from the Electronic Drug Resistance Register. And these are some of the preliminary calibration figures to these data. What is clear is that for proportion of TB cases with drug resistance, they were fairly consistent, but for numbers of diagnoses, particularly in the earlier years, the model was not capturing the trends, but the data was also looking fairly unstable. So that's yet to still be understood, unpacked, and unpacked. Okay, so the general approach for conducting the analysis on estimating the program costs. So we use the Tembisa model to generate target populations. So these are the numbers of the populations that the stakeholders, including National TB Program stakeholders and the National Strategic Plan, deemed to be feasible and that needs to be reached. And then, so we had engagements with those groups of people to decide on the coverage levels. And then we also used average costs of individual interventions. These are based on a newly developed national TB cost model that was done by a team here at HERO. And also to estimate the total cost of each intervention is simply the product of the average cost and the target population that is reached. And all the costs that are estimated are based on from the provider's perspective, and we using US dollars and have not discounted for anything. So these are the descriptions of the populations that we have modeled. So for prevention, we are including isoniazid preventative therapy for people with HIV and for household contacts. Sorry. And also, we also look at included 3HP, the shorter regimen, the 3 months regimen. And for screening, we looked at considered screening at general public health facilities, and also household screening for household contacts, and also door-to-door screening. And we also looked at the digital chest X-ray, which is fairly new in South Africa. And for testing interventions, we considered Xpert, which is part of the current diagnostic algorithm, and also liquid culture, which is generally done for people with HIV who initially test negative. And then we have the targeted universal testing for the various 3 groups. The PLHIV for people with HIV and people with a history of TB, and for household TB contacts. So this is targeted universal testing. It's testing without a symptom test before. And then the other intervention we have is linkage to care. And in this, we look at the initial loss to follow up before treatment initiation, or the linkage between the gap between treatment, between diagnosis and treatment. And this is the summary of the costs of the intervention. Excuse me. So IPT and for households, it's the same. The screening intervention, among the screening interventions, what is there is that the mobile chest X-ray is fairly high, and I also marked it with red as it's still going revisions at the moment. And we also have the TUTT, targeted universal testing interventions, which are slightly higher than normal testing because they also include follow-up costs. And then we have the treatment interventions for drug susceptible intervention for drug susceptible TB. We have splits. We have outpatient and inpatient, but for a drug resistant TB, we currently have a combined for both inpatient and outpatient, and the cost is also yet to be revised. It's been challenging to get a good estimate that everyone would seems to be convinced or happy that it is right, but we're still working on that. Okay, so this is an overview of the scenarios that we are modeling. So the baseline, first is the baseline, which is the current trajectory of the TB program without any changes to interventions. And the NSP scenario, which is informed by NSP and TB, National TB Program stakeholders, and based on what they deem to be feasible. And then we explored two other scenarios, the two max scenarios, where we are trying to see how we could reach the NTB targets. And just to mention that these are very ambitious and not realistic scenarios. Okay, so this table is showing the in the column for coverage levels is the coverages that were informed by the NSP to be deemed to be feasible, and so this is what we implemented under the NSP scenarios. But we also model each individual scenario to see its impacts compared to the baseline. In the max scenario, first one, we tested increasing TPT for household contacts, and we also looked at maximizing door-to-door screening, which is symptom screening, and we said we would perform this 4 times a year. So an adult, South African adult, would be screened at least 4 or at most 4 times a year, and also assume there is no loss to follow-up after diagnoses. In the second scenario, the max scenario, we also increased TPT for people with HIV and for household contacts and door-to-door screening. But we are limiting, we said it will be 2 times a year, and also include targeted universal testing for household contacts, and also similarly assume no loss to follow up before treatment. So these figures show the trends under the 4 scenarios, the baseline and the 3 scenarios. But all scenarios would lead to substantial reductions in TB incidence and mortality over this period, from 2023 to 2041. But when we look at the 2030 NTB targets, which should be highlighted by the dashed lines, it is clear that we are still further from them, even with maximizing the interventions that we tried to estimate. And in this figures, we're showing the impact of the individual interventions and also the combined interventions and under the max scenario and the NSP scenario. Under the individual interventions, improving screening and testing with experts in the general diagnostic algorithm seem to have led to major impact, followed by targeting household contacts for TUTT with expert testing or for screening, and also providing them with TPT. So targeting household contacts seem to be more impactful. And in this slides, it's a bit busy, but it's a summary of the cost effectiveness of the individual interventions under the NSP assumptions, and also the combined interventions further below. And all these are ranked from most cost effective to least cost effective. And as we can see, symptom screening and testing, followed by TUTT for contact and screening household contacts seem to be the most cost effective, followed by improved linkage to care and TPT or preventative therapy for TB contacts. The other interventions that are much lower were, and kind of to a surprise, but include door-to-door and TPT, door-to-door and digital chest X-ray. But this is also partly because of the cost of the intervention. The digital chest X-ray was really high. That's why it led to be costly and less impactful. For the combined interventions, well, the NSP would be cost effective, but the others also contributed to reducing more mortality and incidence, although they are highly costly. They are very costly. Okay, so just to sum everything, so this work, we've shown that HIV has heightened TB incidence and mortality in South Africa. But the interventions that have been put in place, specifically ART and increased screening, have led to the most declines in TB incidence. And they need to be, the efforts need to be continued in order to maintain the declining trends in TB in South Africa. And we have seen TB rates are much higher in men compared to women. And the various factors that we have shown include lower rates of health seeking among men and the lower HIV testing and ART initiations among men. Explain this. So we need to address these. We've also shown the contribution of other risk factors that drive TB and some of the interventions that we recommend and hope our NTP or the National Department of Health would consider would be addressing these risk factors, such as alcohol, smoking, and improving nutritional status, and also improving screening of diabetes bidirectionally in people with TB, and to help with controlling it. Yeah, and just a limitation that we are aware of is we haven't not included other important risk factors which are highly prevalent among men, and we could have included those. And among the interventions that we explored for the cost effectiveness and future impact, we've shown that improving screening and testing at general PHC would be impactful, but targeting TB contacts for symptom screening, for providing them with testing, without any symptom screening as well, and also providing them with preventative therapy is impactful, and also linking patients to treatment after diagnoses. These were cost effective with over the baseline. And we have shown that the scaling up the TB interventions and to the NSP coverage targets will save lives. Even in the VAC scenario, they would have major impact on reducing TB incidence, but still not sufficient enough to meet the NTB targets. Yeah, and lastly, I'd like to thank the co-authors and mainly my PhD supervisors for Lee, Johnson, and Andrew, and my current team here at HERO, and also some of the funders that funded some of the work. And yeah, this is the end of my talk. I'll be happy to take any questions. Thank you.
Thanks so much, Mmamapudi. Really interesting talk. There's a lot in there, so I'm sure that people will have some questions. We're a fairly small group, so if you'd be happy to, just raise your hands if you have questions, or if you'd rather, feel free to put them in the chat. Finn, I can see your hand's already gone up. Go ahead.
Thank you. That was really, really interesting. There was so much there to think over. Thank you.
Yeah.
I'm trying to kind of narrow I have a list of questions. I was trying to narrow down to work out which way. I mean, maybe one of them, I was really interested in the risk factor stuff that you did. And so I appreciate you didn't model that dynamically, but you were looking at the incidence only. Did you look at, or did you think about looking at what that would mean for mortality as well? Just thinking that you could have these risk factors for increased, so if I understood what you did right, you had risk factors for progression, but you could also have those risk factors also obviously often play on outcomes too. And I wondered if you thought about that.
So we do have the estimates on mortality, but because we weren't applying, the effect was not based on, because we had to, well, my thinking is we were using effects from the literature should have been the estimates of how they affect mortality. So how the contribution on death, so the effect of risk factor on death. But I think the estimates we have would still lie if we do specify that these were incidence based, but this is the outcome on mortality as well. So the reason why we haven't presented them is just because we haven't looked at or used evidence-based effects on mortality, but I think that could be done as well. I'm not sure if that answers you.
Yeah, I think so. Thank you. It was just an interesting one. Thanks.
Okay.
Back to you again, Ben.
Oh man, if no one else
If that's a new hand.
I have lots of questions. I was also interested in the so this is the last part that you did now. You talked about the household contact screening and things, and I'm not sure if I missed that bit, but I wasn't sure. Did you model households explicitly, or I wasn't quite clear how you looked at households there?
Actually, yeah. So I think the proper way to say this, it is TB contacts or close contacts of TB patients, because it was based on the number of cases existing and the sizes of households in South Africa. But generally, I think it deem of it into, say, TB close contact. So what we modeled was close contacts based on inputs on like general sizes of households in South Africa and the number of TB cases that exist, and to see the risk of developing TB in that population.
Thanks
Thank
a
you.
lot. So Dana, I see your hand up. Go ahead.
Hi, Mmamapudi. Thank you so much for the presentation. It's really interesting and really cool work you're doing. I just had a question about TUT. I was wondering if you sort of costed out the intervention as it was implemented in the TUT study. And just because I've heard that sort of may not be the same way that it's rolled out nationally, it might have been slightly different. So just any views on that?
Yeah. So my understanding from what the costing team has done, it is done, well, they got the data from the TUT, the initial TUT implementation, that studies that did the initial implementation of TUT, but then the costing had to, they did some adjustments for if it were to be implemented at a national level. But I will still to be corrected. I can pass this question to the costing team here.
That would be great. Thank you.
Yeah. And if I may ask, are you suggesting that the cost would be higher or lower? Is that what you're thinking?
I don't really know. Yeah, I'm not sure. I've just heard that sort of the way that it was done in the study was sort of different, as if, you know, they would walk into a waiting room and just sort of say, hey, if anybody is a contact of somebody with TB, come talk to me. Whereas, you know, it might be different if it were rolled out, sort of maybe more private, so maybe more expensive, but I'm not quite sure.
Thanks. Tom.
Hi everybody. I'm sorry I came in a bit late to this. Thanks, Mmamapudi, for the presentation. I caught the second half. I just wanted to ask, on the back of a paper that I've recently reviewed, and sorry if you mentioned this already, in calculations of cost effectiveness, are we starting to take more account of post-tuberculosis, lung disease, and disability, which up to now hasn't really been thought of, but obviously we know is a massive contributor to probably QALYs and DALYs?
Yeah. Thanks for that question. At the moment we don't have, but it is a plan of mine to. We recently just added DALYs just for TB disease, but we will add post TB. And I do agree, I mean, also from reading that we may be underestimating the morbidity due to post TB. So yeah, the limitation here is that we haven't included post TB, but we am actually working on adding post TB contribution on DALYs actually. Yeah.
Thank you.
Thanks for that. Mphatso.
Thanks, Catherine, and thanks again, Mmamapudi, for that great presentation. So I was curious about the reductions, percent reductions by intervention, the slide where you showed the bar graphs with each intervention, the contribution of each intervention broken down. So it was interesting and obviously encouraging the impact of symptom screening, and also the door-to-door potentially being having greater impact compared to other interventions. So Catherine, myself, and others are doing similar work, thinking about the potential impact of community-based active case finding interventions, sort of door-to-door screening. I was curious about the parameters that you used and what effect you observed in terms of, for example, coverage. You said 4 times for every adult. Was this assuming the whole population covered, and any differences by sex in terms of coverage, and whether you observe any differences when varying those parameters. So any
Yeah.
comments on that, or maybe if you could share a reference would be helpful. Thank you.
Yeah, thanks. So yeah, first of all, so what we're seeing, okay, it's 2 to 3% seems low, but it is encouraging. But this, just to mention, when we read this, is based off what the NSP and the NTP stakeholders suggested would be feasible. So the target that we aim to reach in the model was based on what they suggested. So, for example, for door-to-door, they said reach about 5 million people in South Africa. And so that was the reach. But how it was implemented in the model, and perhaps a limitation, is that it's not specific to anything or targeting any risk group. So it was just like overall South African population. And maybe if it was targeted at, say, a high burden region or a specific sex, it may have yielded more impact. So yes, so that's just to comment on that. So it is limited to what they suggested, but they were not targeted to anyone. So it was just to the general population. And in the other max scenarios where I said 2 times, so it is assuming that we are screening the entire South African population. So it's about let's see, about in the first one we are doing about 2.7 million symptom screens. That's about like very high and a bit unrealistic. So yes, that it's just like covering the entire population.
Thanks so much, Mmamapudi. I think we're really close to time, unless anyone has a very quick final question they would like to throw their hand up with quickly. Then.
If we do have time, I was just going to ask very quickly, it looked like your drug-resistant TB treatment costs were based on stream, and I thought because Sedona's here as well, who was involved with TB Practical, I just wondered if there was a difference. I have no idea if there was a difference in costs there. Or did we had Sedona?
I think she did speak.
I am here. It was completely different different drug regimens, so the cost isn't really comparable between the two.
But so do you think that means that cost per treatment for drug-resistant TB is likely to massively decrease because we have the TB Practical regimen?
Oh, good point. Yeah, potentially. Yeah, I mean, we haven't as part of, so TB Practical was conducted in South Africa, but the cost data that we have for that is as MSF implemented it, which is probably a lot more resource intensive than it would be if rolled out nationally. So I don't know that we yet have sort of really good costing data on BPAL and BPAL related regimens implemented in South Africa, although Hero, I think, is working on that.
Yeah, so currently the study is still ongoing. I think the main issue has been the sample size, but yeah, like with the current estimate, we're getting like mixed reactions, whether it's high or low, and it's been challenging to get a good estimate. We also worked off the previous investment case. So I think the cost in rands was about 200,000, just working off based on the total expenditure and the number of TB cases on treatment, or drug-resistant TB on treatment, and it seems extremely high. And from the other studies that we were looking at, and that's how we just came on this to rely on the stream study, because everything at the moment seems unrealistic. But we still, at the BPAL study, still ongoing. We have contacts for the other sources you mentioned. TB Practical? They are.
All right, thanks everyone. I think that puts us right on the hour. Thank you again, Mmamapudi, for your talk. Really interesting work.
Thanks.
I'll save all my questions and hope to cross paths with you at the union. Thanks
Okay.
everyone for joining, and
Cool.
be sure to sign up for all of the TB Mac workspaces and newsletters and all of that kind of thing. Thanks very much.